Okay, hi everybody, and so welcome to Pamoza Zoom into Health. We're super excited to have you join us today. And I'm Tamara Wright. I'm the Executive Director of Pamoza International. And I just want to start by telling you a little bit about Pamoza International for those of you who might not know. So Pamoza International works in rural Malawi, and we focus on 5 key areas: Christian outreach, economic empowerment, education, agriculture, and healthcare. And so we really believe in meeting the holistic needs of people in rural Malawi, both the spiritual needs and their physical needs. And all these areas that we focus on are interconnected. So today we're going to dig a little deeper into healthcare. But what you heard the women talking about and singing for you earlier on was just the many, many things that we've been doing in Malawi. We have village Bible study groups, and we have adult literacy centers. We teach people about sustainable agriculture, and we teach them how to save money collectively and how to make money off of their assets, including land and the food that they grow. And we even help young people go to school. Like high school is not free, so we have a scholarship program where they can get tuition assistance for high school, and all these things we do in Malawi. And so our area in northern Malawi has about 33,000 people, and we've been able to really expand our reach since we started in 2011. So today, we're going to go a little bit deeper in looking into healthcare. This is a picture of our medical clinic. They actually call it like the Zoe hospital there locally, but it's not a hospital. It's actually a health post, which is the lowest level of healthcare provision in the healthcare system in Malawi. But a health post allows people to still come and get care. We started this in 2007. We supply medicine there at the health post, and we collaborated with the government to assign someone called an HSA, a health surveillance assistant, who lives in the community and does education about healthcare and also under 5 services. So he's a health promoter and he lives there locally, but we worked with the community to construct this health post. They constructed all the bricks, because everything in Malawi is made from hand. It's DIY to the max. So they molded their own bricks, and we worked with them and partnered with them and raised money for the roof, which is an iron sheet, and the solar light. So you see solar panels here. But every week we have medical clinics here. And just last year, we were able to employ a nurse whom you will hear from later. And she works as our health and nutrition coordinator. And so we see patients here. And these are just people coming to get services. And we also do under 5 services through our HSA. So in addition to this work, our healthcare work is really very involved. There's multiple layers. So we do weekly clinics. These are people here on the top left. You see them waiting there for services at our clinic. We probably see about 300 or so individuals a month at our clinic. And then we also do HIV testing and counseling. There's a huge percentage of individuals in Malawi that have HIV/AIDS. So the rate is around 10% currently. And for a long time, getting HIV testing and treatment and counseling was really taboo. But we've been able to work with community members to encourage them to get tested, to encourage them to get medicine. And we partner with the government to have HIV testing kits. And so we also do under 5 services. That picture on your top right is actually our HSA, our health surveillance assistant. His name is Mr. Piri, and he immunizes babies. He also teaches women how to care for their children. We check children to make sure they're growing and developing well, because about 47% of the children in Malawi are malnourished. And so we just make sure we do growth monitoring checks to make sure that they are growing well. And then the bottom right picture is women that now we are able to see pregnant women for prenatal checkups. Before, there was no way for them to know when they were really close to delivering. So the government in general is trying to discourage women from using midwives so that they can get to the hospital earlier. And so we do prenatal checkups, and we just help them to make sure they have a healthy baby. But the middle picture here, I don't know if anybody knows what this is. So this is a pitletrin, and more than 50% of the population that we serve don't have pitletrins on their premises, meaning their household doesn't have a bathroom. So we're actually encouraging families to construct pitletrins on their own premises so that they can have improved health and hygiene. So these are some of the activities that we're doing in Malawi. And it's really been exciting to see the expansion of our services over time. This year, because of COVID, we really had to ramp up and do more in terms of prevention. So you'll hear Dr. Malewezi later on talk about COVID prevention efforts in general in the country, in Malawi, but locally, we didn't want to wait until it came to the rural areas. We were just really, after seeing what's been happening in the US, we just wanted to make sure that our communities had information about COVID prevention, how to be safe, how to have better hygiene. So we were able to raise some funds last year, about $16,000, that we used to employ COVID prevention facilitators that went household to household, really educating people about safe standards, how to prevent COVID, about hand washing and social distance. And we reached 6,000 families with that method. We're also able to get a truck and a PA system. And when we went around the whole area of TA Chindi, reaching about 30,000 people just through our mobile campaign. So here you see a picture of some of our health prevention facilitators. We made signage because there's no internet, no cell phones, no TV where you can just blast news and information. You literally have to go on the ground to the people in order to reach those that we're serving. And we also have a skill center where we sold 9,000 face masks and distributed them to schools, and we distributed them to households along with soap. So as we were teaching them how to do safe hand washing practices, we also gave soap and face masks. And we had some hand washing stations that were constructed, and we put them at key locations, including the clinic and some schools, but popular areas so that people can wash their hands. And these were obviously, it's no running water, so they were manually filled, but they were touchless, and so people could still like push a pedal, wash their hands, and practice better hand washing. All right, and so that's what we've been able to do. So I'm going to pass it back off to Kat.
Thanks so much, Temwa, for just sharing the work that we're doing on the ground in Malawi. So again, today, if you're just joining us, we are zooming into health. We will be speaking today in kind of a Q&A interview type format with Dr. Bridget Malewezi. She is here with us, and she is joining from Lilongwe, Malawi, so that's the capital city. So a little introduction on Dr. Bridget Malewezi. She's a medical doctor, public health practitioner, motivational speaker, activist, and health columnist. She's a graduate of the College of Medicine from the University of Malawi, and Emory University in Atlanta, where she did her master's in public health with a focus on global health. She has worked in a variety of capacities in health, including country director for Seed Global Health Malawi from 2016 to 2020 in health system strengthening and human resources for health. Prior to that, she served in various roles, including program manager at the Clinton Health Access Initiative, providing technical assistance to several government departments on the introduction of new vaccines for childhood illnesses to Malawi and reproductive health, specifically improved access to long-acting reversible contraceptives. Bridget was one of the first set of doctors at Day Young Luke Hospital and has worked as the head of clinical department from 2008 to 2011. She is one of the founding members and currently an executive member and chairperson of public relations for the Society of Medical Doctors of Malawi. And she is also in the task force for the establishment of Women Doctors Association of Malawi and is currently the vice president of the Malawi chapter of Women in Global Health. In her column in Malawi newspaper on health and wellness, she shares health tips and news and guidance. It's now in its 11th year and has broadened this into social media pages on Facebook and Instagram. So you can follow her on Dr. B on Health. She has also featured on several panels locally and globally as a speaker on women's health, leadership, and management, a topic which she is deeply passionate about, and was amongst a list of 8 inspirational Malawian women for the November 2019 issue of Wealth magazine. In November 2020, she was awarded a Doctor of Excellence Award by the College of Physicians and Surgeons of Malawi in recognition for her dedication, leadership, and years of service to the medical fraternity. Bridget is a mom of 2. She has a daughter and a son. She's the wife to poet Q Malewezi, and apart from her work in health, is an avid food blogger and runs a student recruitment agency called Connected that assists students from Malawi who study in tertiary institutions abroad. So again, we're so excited to have Dr. Bridget Malewezi join us today. So please give her a warm Pamoza welcome. It's so wonderful to have you here. I wanted to say that you have such an impressive resume and bio. You've done such interesting work both in Malawi and abroad. You received your training and education in Malawi as well as in the US. And for many people who who've worked and lived abroad for times, oftentimes choose to stay outside of their home country because sometimes finding work in your home country, and especially in Malawi, can be difficult, especially to be compensated for your skills. So we call this brain drain, where the brightest, talented, and trained health or professionals really seek opportunities abroad. So tell us a little bit about why you chose to stay and work in Malawi.
So thank you so much, Kat, for the introduction, and hello, everybody. I think that it helps when you train in Malawi. So I did my undergraduate training, obviously locally, and I think I got to understand the context and the challenges that were here. So even when I was going to Emory to do my master's, I think what really inspired me was to gain more skills, to gain a better worldview, to come back and contribute locally. So I think that really helped me in making that decision, even though, I think even when I was deciding to come back, people were like, oh, there's lots of opportunities here, you can stay. But I really had a strong conviction and a passion to come back and serve. And I think that what that helped me with was having this dual view of having the local context, understanding, and then bringing this world view of training outside and different perspectives. And I think that combination is also very powerful when you come and have both of those skill sets to contribute locally. So I think that's really helped me in the work that I've been doing since I qualified and came back.
That's great. So I agree, cultural context matters. And so it's, it's important to share your knowledge, what you've gained abroad, but also what you know about home and culture. So we're going to kind of dive in and talk a little bit more about healthcare, issues that Malawians are facing. And, In the United States today, we are discussing COVID constantly. It's, really kind of our greatest healthcare challenge that we are facing in this country. But in Malawi, we know that there's COVID is happening, but you've also faced many other healthcare challenges related to malaria, hunger, malnutrition, HIV. And so in your thoughts and opinions, what do you think your biggest healthcare challenge is that you're seeing in Malawi?
I think I would say it's a combination of what you've just mentioned, right? I liked Temo's introduction. She was sort of providing some context into some of the areas that they're tackling in health. She mentioned, for example, HIV. We have, our rates have been coming down, but they're still relatively high. I think the latest data is calculating around 8 point something percent. We're talking about maternal mortality. We saw those ladies having their deliveries and the prenatal checks. Maternal mortality is 439 per 100,000 deliveries or live births. So relatively high. Even our under 5 mortality, for example, is 63. I think the latest data that we had was around 63 per 1,000, which is high. It's actually come down, and Malawi was actually one of the few countries that was able to meet their Millennium Development Goals. So that was exciting, but still it's relatively high. And when you put that into context, I think you also heard talking about malnutrition. We've got TB, malaria is a big one. It's one of our biggest causes for admissions as well as outpatient visits. So all of that is things that we had before COVID and challenges like that. And so I think what has happened now is, sort of bringing a new disease on top of an already sort of overstretched and sort of burdened health system. I like to also share, because as you mentioned in my bio, I've been working in human resources for health, for example. And when you look at, like, for example, how many health workers are available to provide care for all this sort of issues that I've raised, we already knew, I think around 2-3 years ago, we had a vacancy rate of about 48%. So basically, what the reality for the Malawian healthcare system was that if you needed 10 people to manage these diseases, you only had 5. And so the reality, I think, for us is that we had less than half of what we needed to manage HIV, TB, malaria, maternal mortality, and all of that. And when COVID sort of came on board, it's just, it just adds an extra burden on an already overstretched health system. And the way that we manage COVID, for example, means that health workers have to isolate, shouldn't be managing other cases. So those 5 that were already few, we now take like 1 or 2 of them and then put them to manage COVID. So it's been really, really challenging. I think it's just been a juggling act of trying to manage all of that in the context that we are in.
Yeah, that sounds really complex. So, talk to us a little bit more about COVID in Malawi. How is the general population responding, like, to the news, statistics? How are they responding, in terms of what to do? And how is the government responding as well to COVID?
Sure. So just to provide some context, we have a population of 18 million in Malawi at the latest. And so far, our COVID statistics have put our confirmed numbers, I think as of the 1st of March, it was just over 32,000 cases. We had our first case confirmed case in April 2020. And then we had our first wave around June, July 2020. And then the cases tapered down. We had low case numbers and positivity rates. And then we're currently experiencing our second wave, which started towards the end of December and has, peaked around January. We had high numbers, and then that is slowly coming down. So we're currently at our tail end of our sort of second wave. We've had 32,000 confirmed cases so far. But again, you must realize that, we obviously probably haven't tested everyone. If the reality for our country is that, for example, by the time, I think around February last year, so February, March last year, we had 0 testing capacity. So the government has been, trying to ramp up our abilities to test, manage as well. So there's been a lot of measures that have been put in place. You might know that we did not go into lockdown per se, but we did have restrictions on movements, curfews implemented in different modalities, and schools closed and reopened and then closed again. I think there've been a lot of the usual measures that have been promoted, as you guys have been doing from Pamoza, for example, hand washing stations being promoted, mask use, just general preventive measures. So a lot of that has been sort of promoted by the government. I think the challenge is one, in a context like I shared, where we have so many other issues and problems in the health system, to try and convince people to take this new disease seriously has been a challenge, specifically, especially in the rural areas, and certainly even the peri-urban areas. I think that a lot of people are skeptical, and it's been challenging to ensure 100% adherence to a lot of these measures. So there has been some uptake, and I think there's definitely people who have tried, and there are places where, like, for example, there's no, like some shops and banks, there's no entry without a mask, for example. But I think you don't go far when you start to see that people are not using their masks and so forth. And more so now that we're seeing on the second wave numbers tapering down, that people are also getting to the mode of like, we're getting to the end of the second wave. Why should we continue to maintain these measures? So I think it's how to maintain that information to a population that has already been burdened with a lot of other things, to try and then promote that this is equally important. You must continue to do these measures is been a bit of a challenge. Yeah.
I agree. And, we're seeing the same issues here in the US as well. People are just fatigued. They're tired out. It's been a long process. And not, information can continue to change as we learn more about what's actually happening. And so, another thing too that we've noticed is just in general culture, change is difficult. And one thing for the audience to kind of better understand is that in Malawi, when somebody is sick, it is customary to go to the bedside, to visit in the hospital, to go to the home, make sure that, your friend, your neighbor, your relative is doing okay. And the messaging, that we're seeing both in the US and in Malawi is, stay away, social distance, wear a mask, don't gather. And so those things are so counterintuitive to the way like a lot of our culture is. So yeah, it's definitely a challenge that we're facing as well. One thing that we notice in the US is we talk a lot about like our hospitals are filling up, the beds are getting full, our ICUs are overwhelmed, our healthcare workers are exhausted. We might not have enough ventilators for all the people who are sick with comorbidities and things like that. So there's a lot of talk about that. And we've heard in Malawi that there's only, like 18 ventilators for, like you said, a population of 18 million people. So tell us a little bit more about how the Malawian healthcare system is, what resources you have available to fight COVID and also help other healthcare issues during this time.
Sure. Yeah, I mean, I think that certainly at the beginning of the pandemic here locally, there was a lot of panic around the lack of the ventilators here. But I think one of the things we quickly realized was it's not just the need for a physical machine, right? You also need the skill set that should manage and oversee and monitor someone if they need to be put on a ventilator. And that, again, just remembering that shortage of health workers and the health workforce, that we don't really have a mass number of people who have that critical care, sort of skill set to be able to monitor someone on a ventilator. So essentially, a lot of the focus has shifted away from focusing on ventilators and very sort of that kind of management to focusing on areas where we think that the skill set and the health workforce here can manage. So a lot of it has focused on provision of oxygen, high flow oxygen. So the use of oxygen concentrators, for example, and cylinders, also CPAP, sort of positive area pressure, that possibly would be a replacement to try and do ventilation and other aspects. And I think in general, what we've heard from the clinical teams is that with good monitoring, good staff availability, and these measures, and an ability to also be able to admit patients and be able to screen and identify them in good time and admit them before they're, the prognosis is poor, has resulted in good clinical outcomes. So some of the challenges I think we've seen mainly have been that people often present late. Again, I think because of what we had started talking about, some of those mistrust or disbelief that there's COVID and it's an issue, that often some people were presenting late. And being a new disease, I think we often saw that there was people who were, if not skeptical, then ignorant of, that this is actually COVID and they need to be managed. We do, I think, similar to other countries, the majority of cases locally have been mild cases that have been self-managing at home. So we're also only admitting those who are moderately or severely ill, that need oxygen support or management of other conditions like hypertension, diabetes, and so forth. Because again, similar to all other places and globally, those are the ones that are most developing severe illness. HIV is also one of the predictors for that locally, I think, in the local context. So a lot of our focus has been on ensuring that these populations, the elderly, and all of those who may have comorbidities are either being shielded or when they're ill have had access to treatment. We've had to expand our treatment sites. I think initially, again, our bed capacity in general for COVID management was limited. Initially, they had planned to manage them only at central hospitals and that districts should refer their patients to central hospitals. I think that model eventually proved difficult just because a lot of the districts are so spread out, far from some of the central hospitals, and as the numbers rose, we saw even our central hospitals not having enough capacity. So, I think the management has evolved, but certainly has focused more on making sure that we have solutions that are locally feasible and relevant, understanding that we might not have all the resources available to do what maybe the Western setting has done. But from what we see and hear, certainly our mortality rate, our CFR, the case fatality rate is around 3%, 3.3%. So it's not overly above what the general global figures are. And I think that, again, just with timely intervention, that we can be able to save a lot of people still. Yeah.
Yeah. So, yeah, I mean, definitely in the US as well, we're noticing that for a while, people weren't going to access care for other illnesses and how, detrimental that can be towards managing those illnesses. And you've talked a little bit just about kind of barriers or misperceptions. So I just wanted to highlight that you on social media, on Facebook and Instagram, you do Dr. B on health, and you promote a lot of information, public health awareness and information about what's going on with COVID as well as other diseases. And you shared with us through that platform, a CNN video, which showed Dr. Tamara Piri in Blantyre. She works at the Queen Elizabeth Central Hospital. And she was also, again, kind of underscoring the concerns about people are just not seeking care. They're too afraid to come to the hospital until it's too late, like you had mentioned. So in terms of, other chronic health issues or malnutrition or any other, concerns that would bring people into the hospital, are there any other sort of barriers that are keeping people away?
I think that the information, the access to accurate information that is up to date and relevant has been a challenge for a lot of people, certainly in this time where there's a multitude of access to social media and sort of an epidemic of lots of people sharing anything that they want to be able to get accurate information has been a challenge. And so I think we're trying to promote, as you're saying, information that encourages people to seek care, not only for COVID, but for other pre-existing conditions. We've seen already that there are a drop in some of, like, for example, the antenatal visits are slightly dropping because people are scared to go to the hospital because of COVID, or vaccination rates are dropping because people are scared of COVID. So there's personally, I work on my page, but also under the Society of Medical Doctors to just improve on public awareness. We're trying to do public lectures, sort of press briefings, just radio and other measures to get this accurate information about the realities of what is happening. You already flagged, for example, the issues around not having guardians and people visiting in the hospital. I think there was a lot of misconceptions about could there be something sinister happening in hospitals, for example, because we're so used that people are always around the patient, and then people were very surprised. It was challenging for them to suddenly not be allowed to go into the rooms, only hearing that your patient is unwell or hearing that they've passed on. So a lot of that are things that we're trying to, again, to shift and adjust and make it locally relevant, make sure that people understand the reasoning behind it, and also trying to find ways and means in which maybe we have a Malawian model of managing and sharing this information so people have access to all the healthcare, both in the hospitals, but also in the community as well. So it's an ongoing process, but I think we're getting to understand that that's a requirement and a need right now.
And so just to kind of engage the audience a little bit too, it sounds like, there's a question coming in about what are some of the biggest hurdles in the way of combating Malawi's overall maternal mortality rate. So again, you were talking about prenatal visits, or people coming in and getting the care that they need during this pandemic. So I'm sure that definitely influences, access to care for pregnant women. But yeah, could you answer what are some of the biggest hurdles that you're seeing in combating Malawi's overall maternal mortality rate?
Sure. And like I said, I think that just to provide context, like, for example, I shared that our latest maternal mortality was around 439. That's an actually improvement. I think around 1992, it was 1,180. So there's been a lot of work in this area to try and bring those figures down, improving access to facilities, improving the training of midwives, obstetricians, also looking at the management. So a lot of resources have gone into managing, sort of improving our maternal mortality. I think the focus right now is mainly when the patient is there, because some of our the biggest drivers of our maternal mortality include, for example, postpartum hemorrhage, preeclampsia, and the high hypertension in pregnancy. So those kind of things are the interventions, the ability for the skill set of health workers, once those, because as you know, in labor and delivery, things can be going fine and then suddenly everything just turns around. So the ability of the health workforce to manage that, the referral systems, the resources being available, and the various measures to be put in place. So there's a lot of interventions in country, but I guess it is still a slow process to get all of it done and quickly. But I wanted to also highlight that it has improved from where it used to be, and it continues to improve. So yeah, and then I think those are mainly the things in the facility. I think Temra already mentioned that there has been a directive not to try and make sure that people do deliver within a facility, knowing also that I think you also flagged about how people live so far away from facilities. For example, I think we know that about 29% of our population lives more than 8 kilometers away from a facility. So if you have a pregnant woman trying to get her to a facility and there's a problem, that might delay you. So again, those pre-facility issues, making sure that they're actually already delivering within a facility where some help and assistance can be provided quickly is something that we're working on. So I think those two areas of what happens before they get to the facility and what happens when they're at the facility are some of the areas where we're trying to tackle, sort of in combination to make sure that we continue to work on the maternal mortality.
Thank you. So I think we have time just for one more question. Sure. Western countries and higher income countries are just not really the leading expert on everything. We have opportunities to do a lot of research and to travel and go places and learn more, but places like Malawi who have more endemic or, more higher rates of malaria or other illnesses, cholera, TB, countries that are like Malawi and other African countries actually are more, have more expertise, have more knowledge, have more experience in dealing with these types of illnesses. And so, what are some lessons that you think Americans or other Western countries can learn from Malawi or can learn from other African countries who faced epidemics such as, HIV, malaria, malnutrition, cholera, Ebola? There's a lot to name there, and there's a lot of work that's been done. So what are some best practices or models that come to mind?
Yeah, I think there's a lot to learn from, and I think there's the exchange of ideas, right? That there's a need to see which sort of, as you see areas where, for example, what we're learning now from COVID is that similar to HIV, there might be stigma, there might have been sort of a need for appropriate information, not being not just sharing the dangers of the disease, but also getting people to understand the need for testing, so forth. So I think there's a lot of best practices that have been done locally and in other African countries around community ownership of activities. We started sharing already, discussing about how sometimes the communities are not understanding or responding to preventive measures. So there's a lot that has been done, as you already mentioned, under other previous epidemics or ongoing epidemics and disease burdens that could be utilized. And I think it is that ability to realize in global health, it's not just one-way traffic, right? We are learning from each other. You can learn from sort of settings like Africa about things that have been done right, and we also continue to learn from the West. So I think there's a lot of lessons learned that we could borrow from each other, even as it's going on now. I think that during COVID, earlier times last year, I think there was times when people were exploring what has been done right in African settings. How come, for example, African settings didn't have as much COVID? What was being done right? So a lot of things that I think we need to explore and be able to share across and really make sure that the information helps saves lives all over the world. Yeah.
Absolutely. Well, it's been such a pleasure to have this time together and for you to let us know kind of what's happening at the national level in Malawi, as well as kind of what you're seeing on the ground. We really appreciate your time. And it's been just such a pleasure to speak with you. I wanted to just engage the audience real quick in a way to say thank you. So Temwa, if you wanted to come back and demonstrate how to say thank you from Northern Malawi.
I just want to say Yewo, which means thank you, to Dr. B. And we're going to have a couple of people here also say Yewo. So again, Yewo means thank you in Tumbuka, which is spoken in North Malawi, where we serve. Where Dr. B is in Lilongwe, and they speak a different language there. So this is also going to be new for her. All right. So I'm going to first ask Leah, please, can we say a good Pamoza Yewo to Dr. B?
Yewo, Dr. B, thank you so much. We really appreciate all your time and that this technology worked so well. So thank you.
And there's like heavy rains going on right now in Malawi. And I was just praying, like, please let the connection work. So this is really amazing. I'm going to ask Liz. Liz, if you can say Yewo to Dr. B for us.
Yewo, thank you. I'm a midwife from Philadelphia, so I'm like so hungry for all your knowledge on everything about your mama and babies.
Oh, great. Thank you. Yewo, Zikomo.
Yeah, and Liz is going to be in Malawi one of these days because she is
wonderful.
just eager to serve. So we'll probably have her on one of our mission teams. And now I'm going to ask one more person today. Okay, Yusuf. Yusuf, if we could say Yewo from one Malawian to another.
Actually, I have Yusuf's book with me. His daughter is my next door neighbor.
Small world.
Very small world.
Yusuf, look, did you know that?
I suspected. I've never met her, but I knew that the next door neighbor to my daughter's house is a Malewezi house.
Yeah.
And her mother-in-law, Mrs. Malewezi, was my teacher in high school. Yeah. And so I've known at least the Malewezi side of the family. for quite many years.
Wow, small
Yes,
world.
yes.
Now,
Small world.
But she has surprised me with the book, and
It's on my desk. So I was like, I saw the name. I was like, yeah, I have it with me.
well, no,
thank you.
you can say thank you in both languages now.
I was going to say zikomo kwambiri or iniao sikomo kwejinji.
Sikomo. Yeah.
So those of you who don't know, Malawi is small, but it's so many people and so many languages. So there's like 9 different languages, and I don't even know if there's more than that, but at least 9. So yeah, many ways to say Yewo. And so we do so much appreciate your time, and we thank you for sticking around until the end, because what Dr. B highlighted was really what's happening at the national level. Her role has really been in increasing public awareness around how to prevent COVID and other diseases and issues that people need to know in Malawi. So she's really been very prominent in that movement. But we work in rural Malawi, as you know. So we wanted to give an opportunity for our nurse, Morris, who is our health and nutrition coordinator, to share with you what she has been hearing on the ground in Malawi, in the villages. And so we're going to hear from her now. All right.
Greetings from Malawi, especially Zoe. I'm a nurse at Zoe, working as the health and nutrition coordinator. The most common issues that we're seeing right now is malaria, but we're also seeing an increase in malnutrition because the foods are being insufficient in some of the households, and also being in this era of COVID. Another issue is COVID-19. Although we haven't seen a case that we can say it was the COVID at our clinic, but being in this era, we're doing a lot of preventive measures issues in terms of COVID-19. In the area that we serve, the people's perception about COVID-19 is that they cannot get the virus. They are strong. Some of them, they think they are believers. They cannot get the virus because God will protect them. And also, people think it's a disease for the urban. It's the disease for the rich, not the poor people, not the people in the rural areas. Once people have the knowledge, people are trying to prevent, but somehow the preventive measures still more needs to be enforced. The challenge I can see is that people are not putting on the masks properly, like as one of the preventive measures, and also when they are in the crowded areas, we were teaching them that they should be social distance, but I think that one is not being followed much, especially here in the rural areas. I think we need to do more in public health. So we need to increase in education and awareness in the communities. Therefore, we would also need to employ or recruit health education promoters who will be doing door-to-door sensitization on health issues so that we reduce diseases in the communities. We would also want to improve water so that people can have clean water, which means we may need to provide the boreholes to the community so that they can have clean water. We may also need testing kits for coronavirus. People in the rural might say that we don't have corona in the rural areas, but the reason could be people are not being tested. So people might think it's not affecting us, while otherwise it's affecting us, but we don't know if we've been affected because we've not been tested. If money was not a barrier, I think I would upgrade our hospital from a clinic or a dispensary to a health facility, because people walk long distances to get health services. Like from here to the nearest health center, it's 10 kilometers away. So people walk long distances to get health services. So if money was not a barrier, we would upgrade our our clinic to a health center so that we can also increase number of providers, because our communities need, I think, a lot of education so that they can catch up with health issues. Thank you very much.
All right, we are so blessed to have Nurse Morris on our staff. It was really an answer to our prayers. And some of you were actually instrumental to making sure that we got her employed with Pamoza. So you see the problems are very complex, you know, at the national level, at the rural level, and everyone's really doing their best to make sure people are educated, are taking preventive measures, and then we're still dealing with the challenges that we deal with all the time. So right now, there's lots of rains, lots of mosquitoes, lots of malaria, there's lots of malnutrition. People are starting to run out of food from their last harvest, and now there's very little that some of the families have to eat if they didn't grow enough last harvest season. So what do we do? Where do we go from here? I'm really excited about what Pamoza has been able to do so far. And we're really just excited to continue the work. So we talked about what we typically do. These are all the services we provide. And every year, Pamoza continues to provide these. COVID has kind of thrown us in a loop because we did not prepare for it. And although we did these COVID prevention efforts last year, we actually, by the time December came, things were looking okay in Malawi. So we said, okay, well, around October is when we prepare our budget for the year. We are good. We don't really need to do anything outside of, you know, what we typically do, the standard healthcare activities. But then come January, we had a lot more COVID cases. And as of now, it's been almost a 400% a plus increase in the number of people who died from COVID, just from December to March. So where do we go from here? We're going to continue the services that we do, but we want to actually invest in getting some more health promoters on the ground, because public education and public awareness we feel is the biggest way to have an impact. Right now, we don't have testing kits. We don't have the vaccine in our area. We don't have a lot of other resources, but we can invest in having some people, some additional health education promoters to go around and connect with families, connect with households, encourage them to put on the mask that we actually did distribute. And although we got to 6,000 families the first time, we still have 30,000 people in our service area that need to hear about these prevention strategies. So we really feel that this is the best thing we can continue doing, is educating our communities, our families, as well as the regular services that we do. So how you can help, we really would appreciate, one, you staying connected. So if you don't already know about Pamoza, you don't get our regular updates, please connect with us. Sign up to get our regular emails, stay informed, or maybe even connect us with other people who care about healthcare work. Sometimes we take medical teams to Malawi. Sometimes we'll take, we don't believe in bringing items like that we can purchase in Malawi, because we also want to stimulate the economy. So if things are available in Malawi, we don't bring them from the US there. But if there are things that are medication that's really difficult to acquire in Malawi, or items that are not easy to get, we will actually bring items. So you can connect us with maybe other healthcare providers that love Africa, that want to do work there, and then stay informed. And then last, you can give a donation. Our budget right now doesn't include any additional COVID relief efforts or COVID prevention efforts, because we thought things were actually going to continue doing fine until January came and the new strain hit Malawi. So we want to raise at least $6,000 more to hire 3 additional health educators, promoters that will go door to door doing health education for the family, so that they don't get COVID. We don't have COVID right now in our area. We don't think we do. We do 6 miles away in Altini. There were some cases there, but we also don't know if we do. So it's just good to be preventive right now. All right, this is a QR code. You can use your phone, you can scan it, will take you to our website. On our website, you can sign up to be on our list. On the very bottom of the website, there's a button to subscribe. on our email list, or you can make a donation. And I wanted to say Yewo, but I really want to take some additional questions from the audience. But are there any questions that we have right now?
So Yusuf had asked about the use of like smoke inhalation, so steaming or ginger, lemon, herbs, and others. And in general, I think our advice has been that for the greater part, most of this have not been proven to be effective as treatment. They can be supportive for your immune system, or just supportive in terms of symptomatic relief. And so a lot of that, that's what we've been advocating to the public, is to understand that they can help, but they're not necessarily a treatment. And I think it's balancing that knowledge to the public of what is actually a treatment versus what is something that can support you feeling better. For example, if you take a painkiller and you don't feel the aches, doesn't mean it's cured you, for example. So a lot of that is balancing that in a population like Malawi, where again, literacy levels are low, and health literacy is also relatively low. So really balancing a lot of the information that's coming from the West and other countries to a local context, realizing that not everything that is being done in the West or locally can be done here. And so it's just, I think we're trying to balance all of that here. But we know that people are using them, but we're trying to make them understand that they should use them with caution. Yeah.
Okay, great. And thank you so much for speaking on that, Dr. B. And also there's a way, if you're on Instagram, on Facebook, I'm young on the outside, but kind of old when it comes to technology. I'm not on social media, but if you're on social media, please, you can find Dr. B on health. She's on Instagram, she's on Facebook, and she has a lot of wonderful educational videos, including addressing these things. What kind of, other ways can people fight COVID, and and also countering any misinformation out there. It's really excellent. And I also want to add, I know there was a question Josiah asked about whether we partner with existing medical missions for our trips. Yes, yes, yes. One of the things Pamoza really tries to do is collaborate as much as possible to bring more resources into the community. So we partner with the government, we partner with especially the Ministry of Health. And so some of those services that I talked about, like prenatal checkups and under 5 services, those are not just done by Pamoza 100%. They're done in partnership with the Ministry of Health or other local health centers, so that we can together collaborate to maximize impact. So if you know organizations that care about this kind of work and you want to connect them with Pamoza, please do so, because we can have so much more of an impact. All right, so I'm looking at the time. I know that
there was one other question
from Ileana. Yeah.
And then Anne.
2 actually questions, and I'll try and address them.
Okay, great. Go ahead, Dr. B.
Sure. So I think both questions were addressing mental health. One was the mental health of older populations. And I think that generally we're very social. Actually, in the spirit of Pamoza, we really do have a very communal kind of society where a lot of people do spend a lot of time together socializing. And I think it's been really challenging for our population to shift from that very communal living and staying together to trying to not socialize. Certainly for our, I think there have been some projects that are looking into shielding, like for example, the elderly population, but it's been really, really challenging. And I started flagging that in the conversation with Kat as well, around even in times when patients are unwell, as they're sick, just the ability for people to not, our culture is that if somebody's sick, as Kat mentioned, we all come in, we rotate on how to come visit them and come visit and the elderly. And that's been a real shift and challenge. So while there haven't been specific studies and data to share what this shift has been in terms of mental health of the older population as well as just the general population, we are aware that it's been quite a really challenging time. We're seeing some resources come through from social work force, the Counseling Association of Malawi, as well as diaspora, who are have skill sets in counseling to provide some of these services, both offline as well as in person. Some are providing these services for free, but I think the access has just been very, very limited. And similarly for health workers as well, there are ways and means in which they're trying to have access, even in health centers and treatment units, to have access to mental health support. But I think also in our culture, it's not a very common thing for people to share their problems. I think even breaking that barrier of saying, I have a problem, I need to get some assistance, is something that we have to start working on. So I think there's a lot of work in terms of mental health in relation to COVID and what has spawned, what it has exacerbated locally. And I think that it's probably similar or probably worse than in other settings. Yeah.
Thank you for that. Yeah, mental health is definitely been a challenge. And as you said, Ileana, in the chat, it's worsened. And I don't think that's just something we're seeing in the US. It's global, especially for places like Malawi that are so social. So one of the things you heard Nurse Morris talking about is, you know, we're telling them social distance, but the culture is all about coming together and being together. And now you're going to tell me to social distance. So, you know, the things that we often can do easier in the West, like we can right now have a meeting on Zoom because of technology. Well, if those technologies don't exist in some of these rural settings, it's hard to say, hey, stay away from each other and practice social distance when that's the only way you really connect, right? So these are the realities that we're facing.
Yeah, we've had a challenge actually because our limitations, as I said, we didn't go into lockdown because it was not feasible. Just knowing that our culture is very transient. A lot of people do live on hand to mouth and day-to-day living. So, for example, you know, to try and limit mass gatherings, we try to limit them to 50. It's just impossible, really. I mean, it's been really challenging. People still are going to funerals. People are still congregating in churches. It's a very, very communal community and society. And I think to try and explain and understand that these measures are actually preventive for people who feel like this is their only time to come together and share and come together and be with other people has been really challenging. But it's been taking off a little bit, but you know, we continue to try. So yeah.
Awesome. Well, our prayers that this is not going to be the last time we're interacting with Dr. B. She's a wealth of knowledge and information, and 1 hour was insufficient for us to dig into all that she has to share. So, but I do thank everyone who participated today. Thank you for your support of Pamoza, especially our healthcare work. We're looking forward to keeping you updated. Our big dream and vision is that little health post you saw over there with all the dirt roads leading to it, one day it's going to be an awesome, amazing facility. It's a health center that meets a lot of different healthcare needs of the population we serve. And I think with your partnership, we can definitely get there. So I'm just going to conclude with our motto, okay? Which is based on an African proverb. If you want to go fast, go alone. If you want to go far, go Pamoza. So I really pray that today, as you are going about your day, you'll remember to go Pamoza with other people. Thank you so much for your time today.